Good evening, and thank you for joining us. Tonight is the sixth program in our six-part series on diabetic retinopathy in partnership with our friends at Genentech. Throughout this series, we have explored what is diabetic retinopathy, its causes and symptomology. We've discussed treatments, how to improve outcomes, the social determinants of health, and even touched a little bit on clinical trials. However, there's one topic that we have yet to discuss, and I might add, it's just as important as all the others. Tonight, we're going to be talking about shared decision making and how truly engaging in it can have a significant impact on the course of your treatment. This is a discussion that you don't want to miss because it helps connect all the dots from all the previous programs. So I don't know about you, but I cannot wait to get started. But before we begin, we have to remind you to let us know where you're watching from. That means just drop your city and state right there in the comment section. We'd like to give a shout out to everybody and their city and state. Also, if you know someone who needs this information, please tag them or share it on your page. We'd like to get this information out to as many people as possible, and we're asking for your help to do that. And finally, if you have any questions about anything that we talk about tonight, please drop those in the comments and we will get as many of those questions answered as we can. Finally, I need to introduce our expert who has been with us on each step of this journey, and that is none other than Dr. Joseph Kony, our favorite ophthalmologist. I have to add that at the end now, every time I say your name, Dr. Kony, so you just got to get used to that. So, good evening, Dr. Kony. How are you?
Ellis, I'm doing great. Thanks for having me.
That is great, great. So I'm hoping your Thanksgiving was fun and you got some time to eat some turkey. I heard we discussed before the program you're doing some traveling, so I hope you're able to get some turkey or something.
Well, I spent my Thanksgiving in London at a meeting, but the people of London showed great hospitality, and fish and chips were great. But I have the family with me, so for me, every day is Thanksgiving. I'm just thank you that I can get up every morning and just do what I do. So, but thanks for asking.
No problem. Sorry. So we're going to start with the easiest question. When you hear the term shared decision making, what does that mean to you?
This is actually an interesting question you asked because when I was in London, that's exactly the conversation we're having. And so, to put things in perspective, London, for example, have a work shortage very similar to what we have in the U.S. They have so many people and not enough eye doctors, where they look at eye communities, and they have nurses, healthcare professionals, and then everyone acts under the leadership of an ophthalmologist. And part of that journey for them is that it's really important that once you're plugged in with an eye physician, they have a nurse that will help you on the rest of that journey, which is the bridge between the eye doctor and then the ophthalmologist. Now, I think here in this country, we do the best we can. I think those institutions, for example, I think are really good examples. Our EMR systems have allowed different physicians to talk to one another. It's a little bit harder when you're in private practice because the systems may not always talk together. But if you're under the one umbrella, the general practitioner can see and communicate with other subspecialists much easier. They can make those appointments for you. They can check on lab results. They can see how those exams went. And then if there's an emergencies, they can communicate pretty easy. It's a little harder to do in private practice because you have to physically, I think, pick the phone up and call an office or get an emergency appointment or follow up with labs. But it can be done. In our office, because I'm an ophthalmologist, and when people come see me, they already have advanced eye disease, and so we typically will send a letter all the time to the recurring physician, to the referring physician, and also to anyone else that is important in the decision making for that patient. And I think that's critical because a lot of times what I find is that physicians are doing the best they can with the patient, but what they don't see is the underlying organs progressively getting worse. And from an eye standpoint, I can see that the diabetes is getting worse in the eye. And so I would send a just very nice letter saying that I need better or tighter control for the patient
Mm.
because the patient, you may not see the patient eye getting worse. You may not see them getting worse from a kidney standpoint. And I know that once the eye is getting worse, the kidneys are next. And then you also increase risk of peripheral vascular disease. And next thing you know, you have a heart attack and a stroke. So these are all the things that we can do to help have that decision done for that patient to make sure that we're maximizing things in order to prevent long-term effects.
Wow. So it sounds like our partners across the pond have got it figured out to where it becomes a community. So how
Well,
important is it?
I think sometimes depending on what's going on in life, you're forced to make certain decisions.
Mhm.
I'm not saying it's a perfect system,
Right.
because what they don't have is now I think, to bring that circle for us, what we offer is a more custom approach. What
Okay.
they follow are more protocols. And so there's always problems with protocols. And sometimes protocols will lead to more aggressive therapy and unnecessary treatment because they're following guidelines.
You're right.
Here in the US, we have the ability to customize therapy and go along with the patient's journey. You understand?
Okay.
And I think that is still the best way to go. But we still need that bridger. And I think the academic sections have done a good job with I'll call them physician extenders, using the nurse practitioners using the physician assistants to
Mhm.
help see those patients, and then try to triage some of the more advanced or sicker patients to see the physician, in order to take care of everyone that you know that needs treatment.
Right. So how important is it from a physician standpoint, is it that the patient really engage in the shared decision-making process?
Um, not I don't think it's not enough. I think patients are not aware on how much, I think, authority they have when it comes to making decisions. Whether it be just from having lack of health literacy,
Mhm.
uh, not knowing the right questions to ask, just being nervous about talking to a physician. Um, I think is an issue. I think one thing I've learned during COVID, and I think I've mentioned this before on this show, that the most important thing for me is really how the patient perceives their appointment with the doctor.
Mm,
If you look at the issues that patients have with their physicians, communication always comes at the top.
right.
And during COVID, when we weren't as busy, when patients weren't allowed to come to the clinic, we had to minimize the individuals coming in. I had the ability to take a little bit step back and talk to patients a little bit more, learn about their journeys, understand why was it hard for them to come to the office, why was it difficult for them to get their medicines, you know, talk about access to care, how far they had to drive, what was going on in their personal life, that was a barrier for them, for us to maximize their treatments and their follow-ups. And so what I've learned about that is that if a patient feels that you have not addressed their concerns
Mm,
the way they felt it needs to be addressed, then you didn't do a good job. Now the physician can do everything right. They can make the right diagnosis, prescribe the right medication. But if the patient did not feel that you did a good job, then that whole encounter wasn't very positive. And I think positive part of that having been a positive relationship or that appointment is have the patient understand what questions to ask. How can they become an advocate for themselves
right.
and really comfortable in talking to the doctor, and even talking about second opinions or other things when things may not be going right. These are all normal things. And I think that the more patients know about the disease and their problems, they will feel comfortable. But they should be part of the decision making. And I think that it makes it easier for both parties. And long term, I think it's better for the patient because they can understand some of the pitfalls of
Mm,
not keeping those appointments, which is very common in the population that we treat.
yeah. So, and there's a lot to unpack there because you're talking about um, really there could be some situations where the doctor does everything right and then the patient still doesn't engage. But it also sounds like that process requires a little bit more time spent with the patient, to get to know the patient outside of what they're presenting with. So that's a kind of a tricky tightrope to walk on. And how much does managed care, play a role in how much time you spend with each patient? Because managed care says I got to see so many patients, in order. And so how much does it play a role in terms of hindering the shared decision making process?
And I think that's where the physician extenders will be very helpful.
Yeah.
And I think what we really need going forward is someone in the back office following up with Mrs. Johnson. Say, hey, Mrs. Johnson, we know that you're in seeing Doctor So and So a couple weeks ago. We recommended you get an eye exam. How did that appointment go? Were you able to make that appointment? Was
Right.
everything okay during the discussion? So that's one thing I think we don't have. We don't have how can we close that loop? And uh, I think some centers are doing it better than others.
Yeah.
Some centers will have a dietitian or a nutritionist that follows up with a patient. But I think going forward is really, really important. And even going forward, even post COVID, we had to find ways on how to minimize patients coming to the office and try to maximize, how we could keep them healthy without coming in so often. And I think that these type of virtual calls, at least for things intermediary, intermediary, may be very, very beneficial. And then have everyone talk to one another. And if something doesn't look right, then that patient needs to come in. So I think our health system is going that way. I think that AI or artificial intelligence will also help us to know when to institute therapy in certain diseases. I
Right.
think definitely in ophthalmology, we're moving there, and I think that in other subspecialties, we'll be doing the same thing.
Yeah, I love the way you put that in terms of closing the loop, right? Because I think a lot of times, speaking from a patient standpoint, once you have that first initial appointment, or once you've had that appointment, it kind of feels like you're on an island until you show up for the next appointment. And I think if you had that person that would follow up with you, just that call, that little nudge that says, if you're contemplating, if they give you a referral to somebody else, or they give you, follow up, hey, you need to go, I've got a great nutritionist that can kind of help you control your diabetes better, you know, then, and if you don't do it, then you get that call that says, hey, we gave you a recommendation about a week ago. How did it go? And you didn't do it. You might feel that kind of more responsibility to go get it done. So I think it's a two-way street. We just got to figure out how much responsibility is on either side of that street, right? So how much do you close that loop from the practitioner side, and then how much is the responsibility of the patient to really say, okay, how engaged am I in my health in terms of making, working with my doctor to make that decision.
That's right.
So when you're dealing with specifically, particularly with diabetic retinopathy, where the kind of the impetus of it is diabetes, you recognize, hey, you've got a nutritionist there, you've got somebody there that can talk to them about controlling their diabetes. um, when somebody does, the patient in that shared decision making process, does the patient have an outlet or somebody uh, that they can reach out to for more resources in terms of being able to ask additional questions? They haven't seen you, they've got that nutritionist. Is there a place where they can go to get additional resources besides Black Doctor, of course?
Right. So on our website, obviously, we have a lot of content.
Mhm.
Um, with this whole information age, everything is really at your fingertips. I think blackdoctors.org is as another great way. And I've actually refer a lot of my patients here, not just for a diabetic retinopathy, just for general health in general, because I've gone through some of the content and it is phenomenal and it's great information
Right,
and it's information about really addressing the needs of the community. And
right.
so I've driven traffic here just in my own patients over the past several months from my interaction with you. And I know the quality of folks you have here, and it's just setting it straight. This is what you need to know, and that's just straight talk, and
Right.
it's talk that everyone needs to know, and it's easy for them to understand. In our office, when you come in, so let's just say you're a new patient.
Yeah.
Before I even come in, my technicians know if it's a new patient with diabetes, you're getting a pamphlet on diabetes, on diabetic retinopathy, and how you can prevent it, and how and what we need to do. If it's for floaters or flashing lights or any kind of inflammatory problems, we have all that information that we actually give to patients. If it's something that is rare and an oddity, we can print that out right there. So for us, it's easy. We also have I have 6 physician assistants that work for me.
Okay.
Once I leave the room, if Mrs. Johnson had no idea what Dr. Coney said, it's their job to go and say, "Hey, this is really what he meant." Okay, this is so, and all of my technicians, they're really educators, and so we have put in place in my office um, uh, those not really barriers, but the assistance that they need to help understand the process which is going on for them. The other great thing I have, again, I think we talked about this before in one of the programs, is just part of the evaluations for the eye is that I have the ability to take photographs and just showing them their photographs in a common way. This is blood. This is areas of non-perfusion, which is really dead tissue, or any other things they may have. It's a big teaching point. Today, I had a guy that came in for a follow up. When he first came to see me, his blood pressure was like 234 over 120. And
Woo.
he told me, he said, "Dr. Coney, you told me that uh, I need to get out of your office and go right to the emergency room." And he told me this like 2 years ago. And I'm like, well, that sounds like something I would say. So I showed him the photograph from like 2 years ago today where all the bleeding had just disappeared. His optic nerve was swollen and his eye was very angry. He's still 20/20. And he told me that the ER doctor, when I sent him there, that if he hadn't come in, that he would have probably died, and then your ophthalmologist kind of saved your life. And so, just showing people their photographs, and he has nothing going on now, but he comes in just once a year because his blood pressure is stable. But just by controlling your blood pressure, his retina, all the bleeding went away, all the cotton wool spots went away, all the swelling from the optic nerve went away. And so you have these little impacts just by showing someone.
Yeah.
And part of that, that part of that discussion is that, and when you go see your doctor, ask him, how are my kidneys doing? Do I have any heart problems? Checking your cholesterol. So when he went to the emergency room to have that discussion for the first time, because he didn't know he had high blood pressure, he was able to ask some of the questions that I asked him because those were my concerns. And so this helps. This helps the advocate. This helps the patient be an advocate for themselves, because just by having the discussion with their doctors, they can still have those same kind of conversations with the other doctors that they're seeing. If I'm seeing someone with inflammatory issues in their eye, I'm asking about their bowels. I'm asking about joints and
Right.
cartilage issues. And
Right.
so when they go to their doctor, they can have those questions. Say, "Hey, do I need to see a rheumatologist for these things that Dr. Coney mentioned?" And so that is what I mean by completing a circle, and then asking the right questions to make sure we have the right information so we can target the right issues to take care of the problem.
It sounds easy. And as we laugh, because we know, like, of this side of it, it's not easy. But I will say this is that there's a key thread in there, is like asking the right questions, right? The right questions will get you the responses that you need. And so, one, you talked earlier about addressing the need that they came in with, and then what they came in with might not be their biggest problem, but they don't know that that's their biggest problem. We talked about this last week. We did some shows on Thanksgiving and diet and eating through Thanksgiving, because we know how it is. I mean, we go, you get the big plate of food, you got the pies, the cakes, the whole nine, and then we put on these holiday weight. The thing is that if you don't know what you don't know, right, and then I think the story that they told was a lady presented to the hospital emergency room thinking she had a stroke. The doctor walked in, started talking to her about her weight, right? Automatically, she shuts down, because she's like, "I'm not here about my weight. I'm here about, a potential stroke." The doctor that was on the program said she went in afterwards and said, "Okay, why are you here?" "Well, I was here, and he keeps telling me how I'm obese." She addressed the concern about the stroke, and they did all the tests for the stroke. But then she also said, "Okay, look, now here is how your weight is impacting potentially your susceptibility to having a stroke." And that made the patient open up and want it, because now they can say, okay, don't just come in leading talking about my weight when I came in for something else. And I think that's what you're really kind of referring to, is really address what they came in for. And then they're open to listening to whatever else you might have to say. They may come in and say, Doc, my vision's blurry. I got some headaches. You do an eye exam and they got a bigger problem than blurry vision and headaches. That's a symptomology. And then you say, okay, well, we could do this for that. But if we really want to take care of this, there's a bigger issue that I'm noticing in your exam, and then they'll talk to you about it. So, how do we get more practitioners to kind of follow that model of addressing the concern first, instead of trying to fast forward to what the biggest issue might be?
All right. I will say, I agree with you 100% about your comments. And I think the best example that is smoking. I'll come in the room, and it just smell like a chimney is in my office. And they're coming in with blur vision or a stroke in their eye, for example, or even a recent stroke or a heart attack, right? And yes, those are the issues. But we all know that smoking is a big risk factor for atherosclerosis and strokes and heart disease and blockage in the eye and even inflammation. And you can control all the other risk factors, and yet patients can't understand. They can't make the correlation on why they're smoking. So I think that's another example on how to educate people about some of the social habits which may be exacerbating their medical problems. And the other question was, how do we get doctors to make that transition? I think doctors are really making the transition. I think the problem here is just a lot of people and not enough physicians. Today I saw nearly 100 patients, and this could be very taxing days. And I'm not saying we don't have the support group to do that, because obviously we do, but we cannot address every single issue, every single time. For me, it's a little bit easier because I'm a subspecialist, so I'm only looking at someone's retina. But take that same time where you kind of see a medical doctor, and that person has kidney problems. They have, neuropathy. They've had a heart attack. They had a stroke. They had heart disease. They have retina, and they have so many problems. Then they may have a rash going on, or a cold that day, or maybe some signs of a pneumonia, right? Because now we're in RSV season and influenza, and how do we separate COVID? There's a lot that goes on when someone comes in where they have shortness of breath. Is this an acute problem? Is this emphysema? Is it asthma? Or is it exacerbation of a heart, which can lead to congestive heart failure? So you may not be able to address everything because you're addressing something new that a patient came in for. And I think it's tough. I think that we have so many sicker patients, and it is sicker after COVID, right? People didn't come in early, in time. I saw patients today, had a retinal detachment, told me lost vision a year and a half ago, and is just now coming in to see me.
Oh, wow.
I'm like, how can you not see in one eye for a year and a half? And it's the same thing that goes on with other problems. In his other eye, he had 8 tears in his other eye. So I had to, an eye that's bad, yes, that needs surgery, but I really had to put my attention on the other eye that he didn't have a problem with, because I didn't want that eye to end up like the eye that he came in for.
Right.
So I shifted my attention to the good eye, and so we need to work on this one first to make sure it stays good before we address the problem you came in with. And that happens in medicine. But I do think the most important thing is that for chronic problems, we need to have that middle person to help tie in everything. And again, I'm gonna keep talking about physician extenders because I really think this is the way that the country needs to go.
Yeah.
And I think we have, and even in surgeries, we have more nurses and anesthetists helping out the anesthesiologists, because we have to run more rooms. We just need extra support. And the nurses are critical in our field. And if you don't have a good support team, you can't run an effective office. If your patients can't understand things, you can't run, you just can't touch all the lives you need to. So for the chronic problems, I think that's where you need to have everything. And then for everything acute, then that's when you really have to be, the physician themselves have to be more hands-on. Yeah. And that may help decipher on, how we triage patients. So I think going forward, we just got to find a better way to triage people. And I think virtual exams are not going away.
No.
You used to have to go in to get your blood tested. Well, I don't think you have to see a doctor for your blood test. You can go get your blood test. Your doctor can call you with the results, and then figure out when to see, when to make those appointments. I'm not saying that we have to go back to the old days where there's a horse and buggy that comes by your house. But I will tell you, there are people that I know, even in my own specialty, that are doing concierge medicine, where they're actually going into the patient's home and giving them their injections in their home. This is not a wide adopted concept, but it's an opportunity that people see that they can impact certain parts of society. So that may be something in the future. How do we use um, the places we shop, the Walmarts of the world, the Targets, as a tertiary care center that they can go in and see a doc there, or have, a blood pressure cuff machine or a photograph where it can take the eye. Um, these things may be coming down the future, so I wouldn't be surprised because we know that 50% of the people that are not coming into your office, guess where they're going? They're going to the Walmarts, they're going to the Targets. So sometimes you have to meet the
Yeah.
people where they are in the community for them to feel more comfortable. And I think all this is going to be important. It's not just one answer, but all these things are going to be important in order to just have a healthier community.
Well, absolutely. I'll say this. I'm not going to say the name of it because I don't want to endorse anybody. But I signed up for a concierge medical
Hmm.
service, and they came to my house and drew my blood. And then my first visit was online. My initial visit was online, and we went through all the results right there, face to face. And then if I needed to go into the office, for example, like I hadn't gotten my shingles vaccine, right? And I'm of the age where I should get the shingles vaccine. They're like, okay, well, we've got that here in the office, so let's make your appointment. And that's when I would go into the office. But after that, I check in every 3 months. They send somebody if I need to rerun some labs. They come back to the house, and so it definitely is convenient. And I will say this: it's not overly expensive, right? They don't take insurance right now. This particular service that I use don't take insurance directly, but they take it indirectly by because I can use my HSA card to pay for it, and I pay through that to my employer. So they do take HSA cards, and then you can submit some of the tests to your insurance to have reimbursement done if you had to pay for something out of pocket. So it definitely is, and there's more services out there like that, and there's more services out there popping up, and I think that is the gap from the healthcare side. The gap on the patient side, because we got to speak to both of that, comes from really just educating yourself like that. Like we talked about before the program, getting a detailed family history does so much in terms of really helping your practitioner, your primary care physician know what to look for, right? Know if there's some potential barriers and some potential problems down the line, so you can start a preventative process. So if you say, oh yeah, my mom had diabetes, or and she got diagnosed when she was 24, and you're 21, we might start looking. We might have to take a heavier look at your blood pressure, and so on and so forth. So I think really that shared decision making process again is two-way, right? It comes from practitioners creating. I love the fact that you've got a team. I wanted to ask you, like, do you introduce new patients to that team? Well, here's somebody. If you don't hear from me, you're going to hear from somebody from my office, getting them, orienting them to the whole process. And then the patient has to come in with more information, because the more information that they can present to you all, the better that treatment plan will be and more tailored to what their needs are. So what are some of your thoughts in terms of really the patient's responsibility into bringing more information for you, so you don't have to do a fishing expedition to find out what's really going on?
I'm sorry, Alex, you kind of broke up a little bit there.
Sorry, yeah, I saw some sketchiness. Okay, so what I was asking really was about how much responsibility should patients bear with regards to the information that they bring with them into the office?
So I always tell people that you have to give the doctor as much information as possible. I'll use an example here I had recently. Had a young lady come in, had loss of vision, had a stroke in her eye. And the great thing about what I do is really what I see. It's not like medicine where if you have chest pain, it can be like 18 different things. For me, eye pain could be a million things, right? So is basically what I see. So she comes in, I look in her eye, and she has these little particles in her arteries, and they're in both eyes. They're really in both eyes, and she has some blockages. And I have this conversation with her, and I ask, and I'm trying to lead her down the way because I already know what's going on.
Right.
Um, and I asked her about her social history, and I was really kind of honed in on like drug abuse.
Yeah.
And um, she told me at that time there was no problems, etc. And then finally, her second appointment, she did tell me that she had used some cocaine. I'm like, well, I kind of knew that already. I wanted to do some extra testing, so she had that discussion with me. And I told her, listen, I was like, I'm not here to judge you. I'm here to answer your questions and be your advocate. But I can't help you if you can't give me the information. You
Right.
know, a case in point, I had another patient recently who came in with inflammation. The inflammation was a little atypical for his age, and I
Mhm.
clearly asked him some other questions. And it wasn't until he got worse, and he was accompanied by his father, and he asked his father to leave the room, and he told me that he was HIV positive. And I
Um,
specifically asked him, and then what I did the meeting is that I said there are some things that can look like this, and I went through a whole list of things and saying HIV is one of them, syphilis is one of them, you know,
mhm.
herpes is one of them, right? And he denies all those things, and yet when he came back and he was getting worse, he asked his dad to leave the room, and what he told me at that time, he said, "Well, I didn't want to tell you the first time because." There was someone in the room with you. I had an assistant with me who always jots down all my things. I'm like, well, you could have said, the same way you asked your father to leave, you could have said, Dr. Cohen, can I talk to you alone? But by not giving me that information, it led me down to a whole path to do a whole lot of workup. And when
Right.
I was able to get his old labs or his old, and he was actually treated for herpes extensively 5 years ago. This is a reactivation of his herpes because he was immunocompromised because during COVID, he lost his job, lost his insurance, and then wasn't taking his medication. It would have been a very simple conversation, and I would have got him plugged in right then and there versus me having to start all over trying to put the pieces of the puzzle together. So the more the patients can give about their own history, about their own journey, about their family history, particularly if there's something unusual going on, some kind of inflammatory, if you have lupus in the family or sarcoid in the family, these things are very common in the African American, you know, community and easily passed on. And so if doctors know that there's an inflammatory problem, they can understand some things. If you have ulcerative colitis, for example, or
Mhm.
Crohn's disease, psoriatic arthritis. There's all these things, these inflammatory things tend to run together. They call connective tissue diseases. So by knowing that, it gives a doctor a starting point on which diagnostic tree to go down, and to help you out as soon as you can. But
Right.
that social history, if you are doing things socially, drugs, etc., those things are really, really important for the doctors to know so they can target in on that and then address what needs to be done so that you may have the best benefit from what we can offer.
Man, you're touching on some things right there because I'm literally sitting here going, you know, I, I'll speak very candidly. There's been some times where I'm filling out that form, and do you do this or do that, and you pause, right? Because you there might be a little bit of guilt. I mean, be a little bit of shame associated with engaging in these type of behaviors. Am I drinking too much? Do I not report that I'm drinking like I am? And you're right. The doctor's going to find out. They're going to take a look. They're going to see some inflammation, maybe some early signs of inflammation in the liver or whatever. They're going to find out what's going on eventually. But what it can do, and what we're trying to stress for our viewers here tonight is what that does do is eliminate what Dr. Koenig talked about. You know, chasing down different rabbit holes when they kind of know what it is, and it also eliminates those people that drop off, right? Because you could be telling them one thing, if they don't get all the information, they could feel some kind of way, or if they confront you with, well, if you had confronted that patient with what you saw in her eyes, she may not have come back, right? And so and got the treatment that she needed. for her eyes because she felt like you called her out, right? And so, and that's on her, but she'll blame you for that. And then now we've got a patient that's out there that needs help but doesn't. So it's really, really, really a sticky journey for patients. But I would say this to anybody in this audience that's listening, that's watching us, be honest, right? Just be honest, because your labs are going to tell the truth. Your workups are going to tell the truth on what you're doing, and so it's better to be honest because you can get to a real workable solution a lot faster, and that's where we're talking about that shared decision making. You can only make the best decision when you have all the information in front of you. Much like if you're buying a car, you're buying a house, you want all the information you can on that property, on that vehicle, so you can make the right decision. Your doctor is the same way. They want as much information about you and your history, whether it's your family history or your personal history, so they can make a better decision with regards to your treatment.
I mean, I have situations where I think patients want to be honest, but maybe their significant other was in the room. And it is very difficult to ask your spouse to leave the room when your doctor's there. So, if you don't want to talk about that first time, that's fine. But on your follow-up appointment, maybe not bring the spouse with you, or make that phone call like, "Doc, listen, I didn't feel comfortable." And I think we're all people in the today, right? I mean, right. And so we understand. And I think what you and your doctor talk about is between you and your doctor. But getting that information is much more important than not. And then you can have to figure out the other piece of that, right? I mean, because there are some things you may have to tell your spouse, depending on what the situation is. So it gets really sticky, but I think somehow that information needs to be disclosed. And I don't think your doctor looks down on you, but I do think this also comes back to patient-physician discordance, meaning, Black patients prefer to talk to Black doctors, and this has been shown over and over in trials because they feel more comfortable in talking to them. And maybe not every patient feels comfortable in having this discussion with someone that doesn't look like them. I'll tell you now, at the end of the day, the most important thing is just to get the right care. And it's more important to have an up-close discussion with your physician, no matter who and how that person looks, because you may not have the flexibility to see someone that looks like you all the time. I mean, here I practice in Ohio. There's only 2 Black retina surgeons in this whole state of Ohio. So if more likely than not, you're going to not see someone that looks like me if you have an eye problem. And that may be the same place in your community. But you have to have a candid conversation. But I think that the way the health has gone over years, physicians and the healthcare community has caused a little bit of that burden, a little bit of that distrust. And I really think it's the physician's job to make sure you tear down those barriers and give you a safe space. I'll call it a safe space, if I can say that.
Yeah.
Give you that safe space where you and he can have that conversation, either at that appointment or a follow-up appointment where where you guys can discuss little things that may be a little more sensitive, I'll call it.
It's funny. That was one of the questions I had on my list. It was how do we create that safe space, right? Because we know, my background is in mental health, and that was the number one thing that we talked about in my training was creating a safe space for your client to share, because there's going to be that rare client that comes in and does that, open and share everything on that first visit. So, but if you continue to create that safe space, then the more likely you're going to get all of the information to where you can make a better decision with regards to their treatment. And I think that can be applied across, many different fields, whether it's, from mental health to ophthalmology and so on and so forth. So, we talked about in a previous program, bias, right? How much, in our social determinant show, we talked about bias with regards to, especially, Black patients, and it comes to diet and obesity and BMI and this whole thing, adherence, compliance, whatever terminology you want to put on it. How do we help our practitioners identify that bias? And that bias could be on the patient side, that white coat syndrome, that that doctor that's not black, doesn't like black people, doesn't know how to deal with black people. How do we try to tone down some of that bias so we can get to the crux? And I know that's a whole nother program. That's a whole nother series in terms of tackling bias. But what are a few things that we could do to help kind of tone down some of that bias so we can get to a serious solution?
Well, I think from the clinical side, I think tone it down is to basically break it down and have a normal conversation.
Yeah.
But more importantly, have an open-ended conversation. Let the patient talk. Mrs. Jones, what can I do for you today? What's going on? What's bothering you? And just hear their story. And I think that once a patient know that you have a genuine interest in their health and their well-being, it brings down a lot of guards. It's kind of like dating, right? I mean, when you first go to someone, I mean, until you let the person talk, it's kind of hard. You can't just be talking about yourself because okay, he only or she only cares about themselves.
Right.
You have to show interest, and that's how you tear down those walls. You sit down in a common way. Use I typically use it. My patients are older, so it's like a touch generation. I mean, this generation love the touch. So I use a non-threatening, put my hand on your shoulder, Miss Jones, how you doing? So it's a non-threatening kind of way. I sit down. I don't tower over them. I'll sit down face to face. I'll sometimes cross my hands or cross my legs, and I give them a time to tell me what's kind of going on.
Okay.
I think that's just the best way. And then you tackle one by one by one. And if you can't do it all at once, you make some notes and say, hey, you know what? There's a lot going on today. This is what we need to address. I'm going to bring you back in a couple of weeks or a month or whatever's going on, or I'm going to get some lab tests. And when we get the results of the lab tests, we can make the decisions. But I also want to make sure we address this. Well, here's some things to think about. I want you to think about yourself smoking. And then when you come in next time, we'll talk about how you're doing. And if you're not doing so good, maybe we can start thinking about a program after. So you don't have to address everything, but give them something to actually think about. And so when the patient leaves, they're like, you know what? That doctor addressed a lot of things with me. They really do care about, some of the things I'm doing and how my actions impact my life. For me, I think communication, everything kind of goes back to communication.
Mm-hmm.
And, I typically see people, they come in with attitudes. So for a physician,
Right.
I have to find a way to get control of the room, because I look at this as my house, right? You can't come in my room disrespecting my staff and this house, right?
Right.
You want to come and have a conversation about what's going on, we can have that conversation. So quickly, I have to diffuse some things, let them know that we're on the same page. I'm here to help you. So there's challenges that we have because patients will come in like we owe them something. So it goes both ways.
Yeah.
At the end of the day, you sit down, you have a conversation, the same way you and I are having a conversation, and then you start putting the piece of the puzzle together, and you start to solve problems, and you have this journey with them, and then you give them something that a roadmap, so to speak, on what you're thinking for those next appointments and what you hope for them over the next 6 months or a year, depending on what kind of medical problem they have going on.
No, you just telling that story, and I thought about this one incident that I had. I worked in psychiatric emergency in a local hospital, and I had a guy come in, and when they come in and present to the emergency room for a psychiatric emergency, especially late at night, it falls in several categories. But if they present by themselves, then we pretty much have a good idea of what it is. It's either some substance abuse, or it's when the weather changes. There's a lot of people that come in that's unhoused or homeless, and they just want to kind of hang out in a warmer, drier environment. So we get that, but you still have to do the interview as to triage as to why they're coming in. So I have a conversation with him, and he immediately starts with the threats. If you don't get this and you don't do this, I'm going to start, blah, 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 blah. And to your point, I had to say, okay, so do you think you came in for help? Do you think that you're going to get help better by threatening me or by having a conversation with me and telling me what your really needs are and what you're presenting here? And he had that moment of, oh, wow, okay. And he backed down, and then we were able to help him and get him the help that he needed. But to that point, you're right. People do come in sometimes charged up, because especially if they're having vision issues, they want to correct it immediately, right? They want it, what's wrong with this? What can you do? Blah blah blah. And I just want to see the doctor. Why am I talking to you? And as they're going through the process, and really, it's just about leaning in, listening. I like what you talked about in terms of hearing their story, because a lot of people, if they felt truly heard, they're going to listen to what you have to say. And I think ultimately, sometimes we get those problems where we have a lack of shared decision making is because the person hasn't felt truly heard. Now you have a limited amount of time, so you can't hear the whole life story. You can't hear the whole thing, but you can get enough out of them to where if they feel like they've shared enough of their story and you listen to them, they'll listen to you in terms of what the treatment plan will be. And when they listen, the outcomes improve. So I know we've been talking a lot here. So and we've been really kind of listing them out a little bit. So as in our final moments here, what are some of those questions, particularly as it pertains to diabetic retinopathy? So if somebody is a diabetic and they're seeing an ophthalmologist, what are some of those questions that will help kickstart that shared decision-making process?
Well, first of all, I want to say that anyone that have diabetes need to have an eye exam. And I'm going to keep saying that that's the most important thing. And that's the best long-term predictor on how you are. The baseline of what you present tells a doctor a story on where you come from and maybe where you're going. And we could turn back the hands of time with earlier treatment to have essentially no vision loss possible. That's
Right.
number one. When you go have that exam and your eyes are dilated, your simple question is, doctor, do I have diabetic retinopathy?
Okay.
If you have retinopathy, how bad is it? And do I need therapy? If you don't need therapy, the question becomes, when do I need to come in again? And make sure you don't miss your appointments, because the doctor will base your follow-up based on the level of the disease that you have. So the majority of diabetic retinopathy does not need to be treated. Okay, I'll say that again. The majority of diabetic retinopathy does not need to be treated. Okay, it's only about 15% of the people with retinopathy that would start developing sight-threatening problems, okay? Or they would develop a retinopathy in general. So that's number one. The longer you have diabetes, the more likely you are to have retinopathy, and then there's a likelihood that it may progress. So that's the reason why following the follow-ups as a doctor prescribed is important, because once the retinopathy starts to develop a sight-threatening problem, and then there's treatment needed, they can decrease that level of disease to prolong your vision.
Okay.
That's the second thing, is not missing the appointments. Once you start your therapy, the therapy most often will be a greater barrier, which means you coming in more frequently in maybe that first year. We know from all of our data at this point, if you continue to follow that regimen, it's a very strict regimen, for that 1 and 2 years possibly, by year 3, you're coming in only a couple times a year.
Okay.
But you have to put the work in up front. So early diagnosis leads to less therapy, leads to better vision. Once you have therapy and you have sight-threatening problems, it takes us about a year or so to get it stable. But once we get it stable, then you're just coming in for maybe long-term maintenance or long-term follow-up. Okay. And then if you need surgery, I think that it's more important to say, doctor, what are my expectations for surgery?
Mm-hmm.
Okay. And, what are my limitations? So some people are just coming in with blood in their eye, and some people have scar tissue in the eye. And so you want him to talk about that. And then more importantly, you want to make sure you address all the downsides of surgery.
Mm-hmm.
Most of the time, the cataract will get worse anytime you go in someone's eye. There's always a risk of rebleeding, infection, detachments. Those are the most common things. So
Right.
you want to make sure you understand the risk, benefits, and any alternative indications of surgery. Instead of doing surgery, is there anything else that may be beneficial? That's really it when it comes to retinopathy. It's a really simple discussion. It's just that for most of us, it's new, and all we hear is diabetes, and you hear blindness. And I'll tell you now, very few people, if any, at this point, um, where we are in society, if you don't have any vision loss, most times you don't need to have vision loss, but you have to have the appropriate therapy at the right time in order to have those benefits.
Right.
And without therapy, you have progressive vision loss. So that's not a good answer by saying, "Well, I don't like that idea. Don't come in. I don't like the injections or whatever." I think they're important because oftentimes what I hear too is that I don't want a shot in my eye, so I don't want to go to the doctor. Well, just think about it. If you don't get those shots in your eyes or lasers or surgery, just think about in a few years, you may need someone to take you to the bathroom. I mean, your quality of life is important. Keeping your driver's license is important. So you have to weigh the pros and benefits. But in my opinion, there's nothing I fear most but losing my vision.
Yeah.
You can take a lot of things away from me, but don't take away my vision.
Yeah.
So you may not like what the doctor has to tell you. Those appointments we know are not very comfortable, as the procedures we do are not very comfortable. But 95% of the time, we can prevent you from losing vision. And that's powerful. We can't do that in anything in medicine. So that's why I love what I do, because I can keep people doing the things that they enjoy doing.
That is fantastic. So we're going to let that be the final word, because you preach the word right there. I want to thank our friends at Genentech again for partnering with us on this series. I want to thank explicitly Dr. Coney for giving us his time. He is all over the world, literally, in terms of talking about eye health. And so he is tireless in his desire to share eye health around the world. And so we've got one of the best in the world, best in the business here. And he was here for 6 episodes. So I want to say thank you again. Thank you, Tina, for saying thank you to Dr. Coney. All of these videos are going to be on our Black Doctor Facebook page, or also on our YouTube channel. We'll do some replays, but really, 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 what's most important for you is, one, even if you're not diabetic, you should be seeing an ophthalmologist anyway. You should have an eye exam every year. So get that done, an annual eye exam. Number 2, if you do have diabetes, you automatically should be getting an eye exam. And you heard, hey, if you don't have retinopathy, sometimes you don't need to have therapy. It's only those small percentage of cases. So don't be so afraid that something is going to go wrong, because if you do nothing, the likelihood of something going wrong increases significantly. And finally, and we'll let y'all go with this, it's your health. You have to drive it. You have to drive it. You have to talk to the doctor. Bring your shame, bring your blame. You got to get over the embarrassment of some of the things that you're doing, some of the things that you're not doing. If you're not keeping up with your diet, y'all need to have that real conversation and talk about why and what needs to be done so you can. It's your health. You've got to drive it. You can't leave it up to Dr. Coney. He sees so many different patients, 100 patients today, 100 patients a day, and there's still 300 plus million people in this country. So it's yours. If it's important to you, then you've got to drive that health and work with your doctor in order to improve your eyesight. Thank you again, and we will see you all next time here on blackdoctor.org. We've got a couple of shows. Dr. Coney, he didn't know it, but he was giving shout outs to other shows. So tomorrow night, we have a show on lupus. So we're starting a series on lupus tomorrow evening. So if you know somebody has lupus, or you think you might have it, we've got a show on lupus. And then on Thursday, we've got a show on Crohn's and colitis. And we've got, because December 1st through the 7th is Crohn's and colitis week. And we're going to do a show on Crohn's disease and colitis. So if you know somebody has that, we've got that happening on Thursday. So we've got a series on lupus, and we got Crohn's and colitis on Thursday. So we got everything covered here on blackdoctor.org. For that, I will say so long and good night, and y'all have a blessed evening.